In the past decade, the number of pharmacological therapies for generalized anxiety disorder has increased. Currently, our choices include the benzodiazepines, buspirone, the selective serotonin reuptake inhibitors, as well as the beta blockers. Selection of an agent would be influenced by patient's characteristics, the adverse effects profile, as well as the existence of comorbid mood disorders, for instance, depression. Benzodiazepines have been widely used because of their rapid onset of action and proven effectiveness in managing generalized anxiety disorder. And these are some of the agents that are indicated for anxiety, which includes alprazolam, clonazepam, diazepam, lorazepam, as well as oxazepam. So how do benzodiazepines work? Benzodiazepines are believed to interact with receptors activated by the inhibitory neurotransmitter GABA, here indicated in blue. So in doing so, they promote binding of GABA to GABA subunit receptors, specifically GABA A receptor, and this enhances the chloride ion influx, leading to hyperpolarization of the neurons. Subsequently, the hyperpolarization would result in decreased neuronal firing, and consequently this would reduce the amygdala-centered circuit activity as well as the corticostriatal thalamocortical circuit activity. And this would result in a decrease of fear, panic, and phobia feeling, as well as providing an anxiolytic effect. The various benzodiazepine agents appear to be equally effective in managing generalized anxiety disorder. However, the choice of agent should be guided by pharmacokinetic differences as well as cost. Short to intermediate acting agents are preferred because they are less likely to accumulate and therefore less likely to lead to excessive daytime sedation or confusion that often occurs with the use of longer acting agents such as diazepam or clorazepate. And the examples of benzodiazepine used for treatment of anxiety-related disorder or panic disorder includes alprazolam, lorazepam, as well as clonazepam. The use of benzodiazepine should be with caution in older adults, in the elderly, in patients with impaired hepatic function, as well as patients with a history of addictive behavior. So among older adults and patients with impaired hepatic functioning, the metabolic characteristics of oxazepam, lorazepam, and also temazepam are generally preferred because there is less tendency for accumulation. And despite its low risk of abuse, benzodiazepines are the best avoided in the patients who have previously demonstrated addictive behavior. The most common side effects of benzodiazepines include drowsiness, lightheadedness and dizziness, confusion, as well as anterograde amnesia and slurred speech. Ataxia, or the lack of muscle control or incoordination of voluntary movement, such as walking or picking up objects, is also common, especially in the elderly, and they are more prone to experience fall and incur injuries. Additionally, benzodiazepines are also associated with the development of tolerance as well as dependence. A benzodiazepine overdose can lead to extreme sedation or drowsiness, a very low breathing rate, confusion and difficulty thinking, slurred speech, loss of muscle control, and it can eventually cause the person to fall into a coma. And a benzodiazepine overdose seldom but can lead to fatality, especially if a person uses the drugs with alcohol or opioids. Basically, the central nervous system depression is if the person is older and takes too much of the drug, they are also prone to experience benzodiazepines overdose and consequently lapse into coma and death as well, because of the accumulation of the drug. A wide range of withdrawal symptoms can occur when stopping benzodiazepines abruptly, and it can include symptoms such as insomnia, irritability, delirium, restlessness, muscle spasm, hand tremors, headache, as well as anxiety and sweating. And even when grand mal seizure or tonic-clonic seizure, a person who uses benzodiazepines for 3 to 4 weeks and then stops suddenly is more likely to experience withdrawal symptoms as compared to patients who are only on short-term use of benzodiazepines. Discontinuation should be carried out gradually over several weeks, or in other words, benzodiazepines should be tapered slowly in all patients who have had 4 or more weeks of treatment to avoid withdrawal symptoms. Buspirone is a non-addictive, non-sedating alternative to benzodiazepines. It is commonly prescribed for generalized anxiety disorder, but usually as an add-on therapy instead of first-line agent. And this is due to several drawbacks of buspirone, which includes the 1 to 3 weeks in symptomatic relief delay, having no impact on comorbid depression, and if someone is having anxiety as well as depression together, and its relatively shorter half-life, which necessitates dosing twice to 3 times per day. Serotonergic cell groups of the median rough nuclei innervating the hippocampus have an important role in the pathophysiology of anxiety. The mechanism of action of buspirone is thought to be mediated through its serotonergic activity. Basically, buspirone binds to the serotonin 1A or 5-HT1A serotonin receptor on presynaptic neurons in the dorsal rough, and the activation of the 5-HT1A receptor inhibits the firing rates of serotonin-containing neurons in the dorsal rough. Buspirone in general takes at least 1 to 2 weeks to have an initial effect or to actually show clinical effectiveness. And generally, it can take up to 4 to 6 weeks to actually show its full clinical effects. The delayed onset of action for buspirone suggests that the therapeutic effectiveness in generalized anxiety disorder may involve more than its molecular mechanism of action at the 5-HT1A receptor. Buspirone is thought to induce adaptations of 5-HT1A receptors and consequently resulting in changes in serotonin levels with chronic use, and eventually resulting in changes in the structure of neurons and basically changes in neuroplasticity. And as neurons adapt to new levels of serotonin, they make adjustments in the number of receptors. They grow the new dendrites or even promote the development of new connection of circuits. So basically, with the administration of buspirone, it is thought that a longer time is needed to allow the brain to make changes that would lead to a decrease in anxiety. Overall, buspirone is well tolerated with mild adverse effects that include dizziness, nausea, headache, nervousness or excitement, and lightheadedness. And these side effects are seen in about 10% of patients. Other more rare but potential adverse effects that have been reported include stomach upset, nausea, vomiting, difficulty sleeping, dry mouth, as well as weakness or numbness. And these rarest side effects are seen only in about 2% of people taking the medication. The side effects are more common when medication is first taken and may even lessen after a few weeks. So the patients actually can get used to the side effects, and it is not a big deal for most people. One of the most obvious differences between buspirone and benzodiazepine, and one of its disadvantages, is the fact that buspirone requires 1 to 2 weeks of administration before it would actually show clinical effectiveness. Buspirone would only show maximum effect after 4 to 6 weeks of administration. Hence, it is not used for acute condition, and by contrast, benzodiazepines mitigate or remove the symptoms of anxiety almost immediately after administration. Other apparent advantage of buspirone includes the fact that it is relatively non-sedative, it doesn't impair psychomotor performance, it doesn't potentiate depressing effect of alcohol or other CNS depressant, as it acts by a completely different mechanism altogether. Buspirone is also non-addictive, and there is no pharmacokinetic change that occur with age. So it doesn't really cause the extreme adverse effects in the elderly as compared to benzodiazepine, which is associated with more falls and injury in elder people. Selective serotonin reuptake inhibitors, or SSRI, have also emerged as one of the group of medication used in patients with GAD, or generalized anxiety disorder. The primary advantage of SSRI is their potential for long-term use without fear of tolerance or abuse. Many SSRIs have effectively treated generalized anxiety disorders in clinical trials, and the examples include citalopram, fluoxetine, paroxetine, as well as sertraline. SSRIs targets the serotonin reuptake transporter on the presynaptic neuron. So the inhibition of serotonin reuptake transporter would result in accumulation of serotonin within the synaptic cleft. So SSRI causes an initial increase in serotonin, and the immediate consequence is to inhibit the rate of firing of serotonin neurons and also the release of serotonin by its action on 5-HT1A autoreceptors on the presynaptic neurons. SSRI is similar to buspirone, and it takes a week or more for positive changes in symptoms to actually occur. So daily use of SSRI for more than a week or two is thought to trigger changes in the structure and functions of neurons due to the changes in serotonin levels itself. So there is various adaptation that might occur downstream of the molecular activation of 5-HT1A receptor. And consequently, this is the reason for its delayed therapeutic effectiveness. Some of the common adverse effects associated with SSRI use include nausea, sexual dysfunction, agitation, weight gain, as well as diarrhea. Although these effects tend to be mild, they may be mistaken for worsening anxiety and may lead to non-adherence of drugs. So patients should be advised accordingly. Benzodiazepines may be prescribed concurrently during the initial few weeks of treatment to counteract some of these anticipated adverse effects. And this can also offset the delay in onset of the therapeutic effectiveness, which usually would need 1 to 4 weeks to happen. Last but not least are the beta blockers, for example, propranolol. First of all, it is very important to understand that propranolol or beta blockers technically is not an anti-anxiety medication like alprazolam or buspirone, which works by targeting specific parts of your brain and causing you to feel relaxed and calm. Although the specifics are complicated, as you have seen previously, the drugs were covered so far in this lecture essentially work by stopping you from feeling the psychological effects of anxiety. Instead, the beta blockers such as propranolol works by specifically targeting the receptors in your heart or other parts of the peripheral nervous system to block some of the physical manifestation of anxiety. Now, if you can recall back the fight and flight response, it is what makes you feel the more physical symptoms of anxiety. When you feel nervous or stressed, such as before delivering a speech, your body ramps up its production of adrenaline and noradrenaline, and these neurotransmitters work by attached to beta receptor, specifically the beta 1, beta 2, and beta 3 receptor throughout your body. And once these receptors are activated, it would trigger anxiety manifestations of physical anxiety manifestation, ranging from shaky hands to sweating to nausea and a very rapid heartbeat. Therefore, the beta blockers antagonize the body beta receptor, thereby decreasing the physiological symptoms associated with anxiety. So essentially, beta blockers block outward signs of anxiety. Since propranolol only blocks beta receptor, it doesn't actually stop the psychological effects of anxiety, and you might still feel nervous before delivering a speech, but it is less likely to result in any kind of physical reaction. And interestingly, although beta blockers doesn't directly affect your brain, it can help you to feel less nervous without the shaking, without the rapid heartbeat, or the excessive sweating that usually happens when you feel anxious. And it can become easier to relax, to perform your tasks, and to stay focused. So again, beta blockers do not treat the more mental aspects related to anxiety, such as worrying of nervousness, but it addresses the physiological symptoms of anxiety, such as reducing heart rate, reducing sweating, dry mouth, and trembling. I think this is the end of my lecture. Anxiety attacks, depression, and others can happen to any of us. Asking for help doesn't mean you are weak. It means you are strong and brave. We are in this together and we will get through this together. حسبي الله لا إله إلا هو عليه توكلت وهو رب العرش العظيم. Thank you very much.